we have our introductions, please, Jan?
I'm Dr. Joyce Neprokowski. I work at the VA.
Say you're a pharmacist.
And I'm a pharmacist.
Vicki?
Vicki Knoll, I'm a pharmacist. I work at McCrory's Pharmacy.
Leroy?
Leroy Candelaria, I'm a pharmacist at Rio Grande Valley Isotopes.
Thank you.
Hello everyone, I want to thank you all for coming out today to hear this presentation. My name is Mayumi Villarreal and I am a non-traditional PharmD student at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. And the title of our presentation tonight is The Use of Canagliflozin in the Treatment of Type 2 Diabetes. First of all, I'd like to start off with a case study. Mr. M.R. is a 52-year-old Hispanic male with a history of diabetes type 2 for 3 years. He has no known drug allergies. And you see his current labs on the slide here, and I want you to pay particular attention to his A1C of 8.3%, and we'll come back to this case study later. And his current medications are also listed here. Now I want you to think about this as we go through our presentation regarding Mr. M.R. Is Mr. M.R. being adequately treated for his diabetes type 2? What are the goals for Mr. M.R.? And can Mr. M.R. be treated with canagliflozin? So we will come back to our case study after the presentation is over. Now let's talk about some of the objectives of the presentation today. At the end of this 25-minute presentation, participants should be able to discuss the prevalence of type 2 diabetes, describe the complications of type 2 diabetes, and recall current A1C and glucose targets that have been set out by the ADA, or American Diabetes Association, and the American Association of Clinical Endocrinologists, called the ACE group, in terms of guidelines for the treatment of type 2 diabetes. Also, we want to review the safety and efficacy of canagliflozin in the treatment of type 2 diabetes in a randomized controlled trial. And given a case study, identify when canagliflozin would be appropriate in the treatment of an adult that has type 2 diabetes. First of all, let's define diabetes. Well, type 2 diabetes, as we know it, is responsible for about 90% of the cases of diabetes in this country. And there are certain risk factors associated with the development of type 2 diabetes. Type 2 diabetes has been defined as a metabolic and cardiovascular disorder where a defect in insulin secretion and insulin sensitivity leads to insulin resistance, also called hyperglycemia. Type 1 diabetes is responsible for about 5 to 10% of the cases of diabetes diagnosed in this country and is thought to have a very strong autoimmune component. Type 1 has been defined as a deficiency in insulin production from the beta cells of the pancreas. Also, both involve disorders of fat, carbohydrate, and protein metabolism. Excuse me. Why is it so important to treat diabetes? Well, the complications of untreated diabetes can be life-threatening and really decreases the patient's quality of life. Those involve microvascular complications, which are microvascular, those vasculatures you see in the eyes and the kidneys, macrovascular, and we often think of the heart muscle, and neuropathic or peripheral vascular disease, which can often lead to amputation. So in this country, diabetes is the leading cause of blindness in those patients that are 20 to 75 years old, leading cause of end-stage renal disease, which often leads to dialysis, leading cause of non-traumatic amputations. And the American Heart Association has even deemed diabetes a risk factor for cardiovascular disease. And in fact, we see the majority of our patients with type 2 diabetes suffering from a cardiac event that may lead to their death. And of course, we mentioned the peripheral vascular disease, which can lead to amputation. Now let's talk about the prevalence of type 2 diabetes in the United States. And these are governmental governmental figures from the year 2012. Now let's define prevalence versus incidence. Prevalence is those cases that are present today that we can count. Incidence are those cases we can predict in the future of occurring. It is estimated that 29 million, or almost 10% of the U.S. population, has been diagnosed with diabetes type 2. And that is correlates to 300 million people worldwide, excuse me. Type 2 diabetes, again, we said was responsible for about 90% of those cases diagnosed. So in this country, in the year 2012, it's speculated that the prevalence of diabetes is 8 million people. Undiagnosed diabetes, that would be present in 21 million people. And at risk, those patients at risk for prediabetes, which is highly correlative to developing type 2 diabetes, estimated that is prevalent in 86 million people in our population, or fully a third of the U.S. population is at risk for developing prediabetes, which oftentimes develops into type 2 diabetes. And again, type 1 diabetes is, we see it 5 to 10% of the cases, genetic component, and we see the highest rate of type 1 diabetes in those Scandinavian countries. Here are some of the risk factors, and we're not going to talk in detail a lot of these slides. I wanted them to be a reference for you in case you wanted to investigate any of the signs and symptoms, if you will, of diabetes type 2. So we know that a family history is a strong correlator of developing type 2 diabetes, particularly in your first-degree relatives. That would be your parents and your siblings. Overweight or obesity, that would be over 20% of your ideal body weight, or a BMI equal or greater than 25 kilograms per meter square, sedentary lifestyle, increased age, ethnicity. We know in this country that those that have heritage from Native, Hispanic, Asian, or African American, or Pacific Islander genetics are more predisposed to developing type 2 diabetes. Also, some other risk factors. In terms of laboratory values, we can predict that if a patient has a history of impaired fasting glucose, where the glucose is 100 to 125 milligrams per deciliter, or impaired glucose tolerance, when you have a glucose 140 to 199 milligrams per deciliter, A1C above 5.7, hypertension, we're talking about greater than 140 over 90, dyslipidemic disease, gestational diabetes, and or delivering a baby over 9 pounds, vascular disease, history of acanthosis nigricans, and a history of polycystic ovary disease. And here we have a slide that has NHAIDS prevalence data. These are national governmental data in terms of the prevalence of diabetes type 2 per age. And as you can see on this slide, as we go up in age, you see the prevalence of diabetes type 2 really explodes. This diagram is called the ominous octag, and this was published in 2013 by Ralph DeFranco, who is a well-known author of diabetes papers in the diabetes circles, and he's at the Texas Diabetes Institute in San Antonio. And his group has hypothesized that not only is diabetes seen as a defect in the beta cells of the pancreas that secrete insulin, but they hypothesize that there are, in fact, as diabetes type 2 progresses, that no shorter than 8 organ systems get involved in the progression of diabetes type 2. And you can see on this diagram the 8 organ systems that are involved. And today we are going to focus on increased glucose reabsorption from the kidney. But you also see the hepatic gland, the lipolysis, increased incretin effect, and all of these organ systems lead up to type 2 diabetes. Now here are some of the characteristics of a person with diabetes. You'll see abdominal obesity, hypertension, dyslipidemic disease, and hypercoagulable states. And type 1, I just want to mention that it's been associated with an autoimmune destruction of the pancreas and occurs in childhood, early adulthood, but now we're seeing it occur in any age. And I just want to mention that 5% of the cases of diabetes are other than type 1 and type 2, and they're thought to be a genetic predisposition to some of these. What about screening for type 2 diabetes? Well, here are some of the screening criterion that the ADA, or American Diabetes Association, says to look for. And again, we've talked about these: obesity, when children are over 85 percentile, plus risk factors for their age, height, and weight, etc. And also, without risk factors, any patient greater than 45 years old should be screened. If they're negative at that time, you should continue screening every 3 years. And we have the guidelines for gestational. Also, let's talk about the diagnosis of diabetes type 2 per the ADA guidelines. A1C greater or equal to 6.5%, fasting blood sugar greater or equal to 126 milligrams per deciliter, OGTT, or the oral glucose tolerance test, 2-hour test, greater or equal to 200 milligrams, signs and symptoms of hyperglycemia with a random glucose of 200 milligrams per deciliter. And why were all these numbers thrown in here? Why are we looking at greater than 126 for fasting or random of 200? Well, studies have demonstrated that there is an increased risk of developing microvascular complications. For instance, retinopathy when fasting blood sugars go over 99 milligrams per deciliter, and for instance when the A1C goes over 5.9%. And I want to mention that as time goes on, we see more patients being discharged from hospitals with complication of type 2 diabetes. Let's talk about the current guidelines. Here, as you see on this slide, current guidelines per the ADA, and in the middle of this slide, you will see the approach to management to hyperglycemia. As you go toward the left, you see more stringent control, and as you go through the right, you see less stringent control, greater than 7. And the push the last couple of years from all the societies or all the guidelines has been to individualize therapy. So in terms of more stringent control, that might be a relatively younger patient that's had diabetes for a shorter length of time. You might want to have your A1C goal of less than 7, more stringent. And then for those patients that are older or have increased incidence of hypoglycemia, had diabetes for a long time, or other comorbid diseases, you might want to have a much less stringent guideline or a goal A1C. Here this slide, you see current guidelines from the ACE, and this is the ACE Comprehensive Diabetes Management Algorithm, which was just republished last month. The last time it was published was 2013, so they've made some nice updates. Here you see a pre-diabetes algorithm. This is the updated 2015 guideline, and I just want to mention that they have impaired fasting glucose and impaired glucose tolerance identified. And they have algorithms of the types of treatment you might want to keep in the back of your mind if, in fact, your patient has prediabetes. And here again, the goals for glycemic control must be individualized. Basically, you want an A1C of less than or equal to 6.5% for healthy patients without concurrent illness or at low risk for hypoglycemic incidence. And you might want your A1C goal of greater than 6.5 if you have patients with other concurrent illnesses or at risk for hypoglycemia. Now here we have the glycemic control algorithm, and I want to mention that first and foremost of any of these patients, the first intervention you want to make is TLC, what we used to call therapeutic lifestyle changes, and the ACE guideline calls it lifestyle modification, which would include diet and exercise, and refer to a dietitian if at all possible, because oftentimes people eat the same types of food and they need help in deciding how to cut those calories down, how to cut the fat in their diet and the carbohydrates in their diet down. And what's nice about this algorithm is that it has different entry points in terms of the algorithm. So if your patient comes with an entry-level A1C of less than 7.5, that may be, your therapy may be different from those patients that come from walk in your office with an A1C, first time you see them, at greater than 9%. And also, I just threw this in here because here is an algorithm for complications of the obese and overweight patient, because obesity is also a risk factor for developing diabetes type 2. And I just have this in here for your edification, the algorithm for adding and intensifying insulin therapy. And it's very nice, it walks you through. And here is also profiles of anti-diabetic medication. So you have, going horizontally, the class of drug, and going vertically, you have the possible adverse drug reactions, which you may or may not want to use that drug in your certain patient. If your patient has these, would be negative for these adverse drug reactions of certain drugs. Okay, let's talk about our agent now, canagliflozin, or Invokana, is Manufactured by Janssen, it is the first agent in a new class of drugs called the SGLT2 inhibitors, sodium glucose transport 2 inhibitors, and it was approved by the FDA in the first part of 2013. Its indication is as an adjunct to diet and exercise in adults with type 2 diabetes. It may be used first line or monotherapy. And I just mentioned down here that it does also come as a combination product, which we won't discuss today. The initial dose of canagliflozin, if your patient is appropriate for this type of medication, is 100 milligrams orally every day prior to the first meal. Now, this dose may be increased to 300 milligrams daily if your patients have an estimated GFR, or glomerular filtration rate, of greater or equal to 60 mils per minute per 1.73 meters squared. If the estimated GFR is less than 60, you want to max that patient out at 100 milligrams per day. However, if your patient has an eGFR, estimated glomerular filtration rate, of less than 75 and you have them on that agent, you want to stop that agent, and if they have it coming into your office, they are not a candidate for the use of canagliflozin. Okay, now here we have the renal handling of glucose diagram, and as we know, the kidneys play a major role in glucose homeostasis via the glomerular filtration and reabsorption in the proximal convoluted tubule of your kidneys, and this is a picture of that system. A healthy adult basically filters 180 grams of dextrose or glucose daily. The kidneys reabsorb the vast majority of that glucose back into the system along with sodium. That's why this is called the sodium glucose transport system. Glucoseuria, or you start spilling glucose in your urine when the tubular glucose load is greater than 220 milligrams per deciliter. And what that means basically is when there is over 180 grams per day of glucose in the system, your body will start spilling that glucose into the urine. The plasma glucose concentration is an important modulator of the sodium glucose transport, or the SGLT system. Therefore, by blocking the effects of the sodium glucose transport system, you increase the urinary excretion of glucose and also pulls out some of that fluid. And so that may be in part why we see a weight loss with these products. Now, if you look at the slide I have here, so it's a two co-transporter system. The SGL1 and the SGLT2 system, if you see on the slides here. So the SGLT1 is also seen in the S3 segment of the convoluted tubule. And it only accounts for 10% of the reabsorption of that glucose back into the system. On the other hand, and that is a high affinity, low capacity transport primarily seen in the small intestine and the heart muscle. Now, if we looked here to the SGLT2 system, this is a low affinity, high capacity transporter system in the kidneys. And it's located, if you look, along the S1 segment of the proximal convoluted tubule, and accounts for about 90% of the reabsorption of that glucose back into our system. And this is found only in the renal system, and it inhibits the reabsorption of filtered glucose and leads to glucoseuria without GI effects. Remember, and you can see at this slide, that if we block the SGLT2 uptake of sodium and glucose, you see the arrow, the star there blocking that system, what happens to the glucose? Well, it is excreted through the kidney system, and you see glucose excreted through the urine. Now let's talk about the safety and efficacy of canagliflozin. We took a randomized controlled trial, and it was entitled Long-Term Efficacy and Safety of Canagliflozin over 104 weeks in patients aged 55 to 80 years old with type 2. This was submitted for publication at the end of 2014 and actually published in the early part of 2015. Now, the design of this trial, it was a phase 3 clinical trial, randomized, double-blind, placebo-controlled. Now, the initial period was 26 weeks, and like I said, this was placebo-controlled, double-blind core treatment, and the extension was 78 weeks, so you have a total of 104 weeks of the study. Now, our inclusion criteria were those adults aged 55 to 80 years old with type 2 diabetes, and the A1C range they had to have was between 7 and 10%. And the patients could be on not any diabetes medications, one diabetes medication, or a combination of medications to treat their diabetes type 2. And of course, the exclusion criterion was those patients not meeting the inclusion criterion. What was the intervention? Well, we had a group on placebo throughout the 104 weeks, and the results of those groups was compared to canagliflozin 100 milligrams PO daily, and placebo was compared to canagliflozin 300 milligrams daily. So you had three groups. In terms of outcome measures, the primary outcome was a change in A1C from baseline at week 104, and the secondary endpoints were percent of patients reaching A1C less than 7%, less than 6.5%. Then they looked at change from baseline of fasting blood glucose, systolic blood pressure, body weight, and change in the fasting lipids. So let's talk about the statistical analysis. Well, we know that the sample size was calculated to show superiority of the decrease in A1C of canagliflozin versus placebo, both groups of canagliflozin. The efficacy endpoints were assessed via modified intent to treat, that takes into account those patients that started the trial but did not finish the trial. The last observation carried forward was used to analyze missing data, and least square means was used to analyze differences between the placebo group and the two canagliflozin groups. So let's talk about the results. Well, our primary outcome was a change in A1C from baseline, and at 26 weeks, all those changes were statistically significant when compared to placebo. So in the placebo group at the end of 26 weeks, we saw a slight increase in A1C of 0.17%, and the 100 group had a decrease in A1C compared to placebo of minus 0.32%, and the 300 milligram group had a decrease in A1C of minus 0.43%. And the key endpoint at week 104 was a change in A1C from baseline. Now in this diagram, it's a very nice depiction of the change of A1C, and in the top graph, which is in green, that is placebo group, and you can see at week 26 where that A1C change was as opposed to week 104. And you could see at the end of 104, the placebo group actually had a slight increase in A1C. And if you look at the latter bottom lines, the graphs, the light blue and dark blue, which are canagliflozin 100 and 300, there was an appreciable change in A1C. Well, what does that mean? What is the clinical significance of the A1C? In this graph, we can't tell because there's no p-value. So let's go to the change in A1C using least square means. And we know that when we compare placebo to canagliflozin 100, as you see here, you have a 90% confidence interval of minus 0.65 and minus 0.32. Now what that tells us is that this range does not include 0. Both of those numbers are under 0. So this means, since they didn't include 0, that this difference is statistically significant. And you don't need a p-value when the confidence interval is provided. And the confidence interval actually provides more detail than a p-value would because it gives a spread of the values. So the closer in range that the two values of the confidence interval are, the more precision you have in reporting these endpoints. And you also see the placebo compared to the change in A1C of canagliflozin 300 as well. And that difference was statistically significant. So again, let's look at our secondary endpoints. In this graph, I have outlined in red the differences in the systolic blood pressure and the HDL. And in fact, if you look at those confidence intervals, those are also, they do not reach 0, and they're it's a relatively close confidence interval, which means that we have confidence that 95% of the patients fall in this interval. So we do have a statistically significant difference in systolic blood pressure and the HDL values a placebo versus the two Canada groups. And here you see a change in fasting blood glucose from baseline. And again, that change, when you compare the placebo to the Canada groups, those changes were statistically significant because our confidence intervals do not meet 0 and they are relatively close. And also this graph shows you the change in systolic blood pressure, and we said already that the change from placebo to the Canada groups was statistically significant. And also the change in body weight. So let's talk about safety. Overall, more adverse events were reported with the Canada groups. They were mild to moderate, and those basically were genital mycotic infections, urinary tract infections, osmotic diuresis, and volume depletion. And the discontinuation rate of the canagliflozin groups was low due to the ADRs, and you see those values there. What are some of the warnings and precautions? Well, you need to look for hypotension because of that volume depletion. You do have to more frequently monitor the renal status of the patient. Watch for hyperkalemia, hypoglycemia, genital mycotic infections, particularly in females and those males that have not been circumcised. And also you want to look for urinary tract infections. So what are the clinically significant results from this study? Well, we saw a decrease in A1C and weight, which were both statistically significant when placebo was compared to the two Canada groups. And few ADRs caused discontinuation of the drug. What are some of the strengths of the study? Well, the length of the study was 104 weeks, almost 2 years, and included a wide range of patient ages, 55 to 80, and the inclusion criteria were rather broad in terms of what drugs the patient could or could not be on. And that's a more realistic scenario to the general population. Limitation of the study is that they did not use active comparators. They only used placebo compared to canagliflozin instead of using another drug used to treat diabetes. And also the study duration of 104 weeks, actually the results were only powered to detect differences of efficacy at 26 weeks. So in conclusions, what is the place of SGLT2 inhibitors in the treatment of type 2 diabetes? It is a novel mechanism of action, very easy to take. It's a PO drug that's taken once a day, which you know is very easy for patients. And the efficacy can be seen up to a decrease of 1% in A1C. And we see a weight decrease of 3.3 kilograms. So what are the summary of key points? Well, the high number of present and projected cases of diabetes type 2 continue to prompt the development and use of new drug entities. The life-threatening complications of type 2 diabetes make drug therapy interventions essential and important in these patients. ACE and ADA provide standards of care and treatment algorithms, but they do stress that treatment needs to be individualized per patient. Summary key points: canagliflozin, which is an SGLT2 inhibitor, is used to treat patients not at goal who have type 2 diabetes, and it lowers blood glucose, A1C, body weight, blood pressure, and is well tolerated in a randomized clinical trial that went 104 weeks. And here's a SGLT2 overview of the 3 products that are currently on the market. And that is the end of my presentation. Now at this time, I would like to go back to our case study. So, are there any questions? No? Okay. Well, let's go back to our case study, and maybe we'll prompt some questions at that time. So, MR is a 52-year-old Hispanic male with a history of type 2 for 3 years. There are no known drug allergies. And you see his current labs, and his A1C is greater than 8%. And you see his current medications. So remember the questions that were posed about the treatment of MR. What is he being adequately treated for his diabetes type 2? What do you all think? And if you look back at that diagram of the ADA, where you have your A1C, whether you want to have it more stringent or less stringent, what would you think on this patient? Yes, you wanted to have that a little bit more stringent on him. He's relatively young. He's in his 50s. He's only had diabetes diagnosed for a couple of years. And remember, most patients when they come in, they've already had diabetes for several years by the time they're diagnosed. But he's relatively young in age and in terms of how long he's had diabetes. So no, so yes, we want to have his A1C less than his current over 8%. You might be looking at closer to 6.5%. What are the goals for MR? Well, you need to decide that in conjunction with MR, because now the guidelines say that we really want to involve our patient in their own care. If they get a buy-in, chances are that you might have better luck with decreasing that A1C and getting them to goals. So let's say you want your patient at where, Vicki? Less than 6.5, okay. So how would you go about that? Well, first of all, you're going to implement diet and exercise with this patient, see if he can lose some weight, and then can MR be treated with canagliflozin? Well, first of all, when you start thinking about treatment, you think, is this patient a good candidate? Why couldn't I use this drug in this patient? Well, first of all, renal. Does he have normal renal function, whether his estimated GFR is greater than 60, 65? You're going to look at that. So let's say this patient does. So in that regard, he might be a good candidate. Does he have a history of hypoglycemia? No. Does he have a history of dehydration or fluid loss? No. So in fact, MR might be a good candidate for this drug. And then you want to bring the patient back within a month or so to check his electrolytes and see how he's doing. And here on this slide that has questions, I put the pictures of the three SGLT2 inhibitors that are currently marketed in this country: canagliflozin, Invokana, dapagliflozin, Farxiga, or empagliflozin, Jardiance. So that's what they look like. Any other questions? Thank you all for coming again. You've been a great audience. You asked great questions. Thank you for asking those questions. They were very timely and very involved in our patient case study. Thank you for coming.